very fortunate to live in a time where the technology for cancer care is outstanding. Today you'll learn about an advancement in the treatment of skin cancer called Mohs Surgery. It's a procedure that Dr. Steffes does on a regular basis. Dr. Steffes is a board-certified dermatologist here with Agnesian HealthCare. Dr. Van der Kooi is also here with us today. He's a board-certified radiation oncologist with the Agnesian Cancer Center. Dr. Van der Kooi is here for a number of reasons, but really to demonstrate the continuum of care for the treatment of cancer that we have to offer within our system. So, please join me in welcoming Dr. Steffes and Dr. Van der Kooi.
Well, thank you and good morning. It's great to see you all here today. It's a great segue. Thank you, Holly. You know, it is a good time, even though it's raining outside. May is Melanoma Awareness Month, and we're going to be talking about skin cancer today, specifically a little bit more involved about Mohs microscopic surgery, but we're going to cover some basic things about skin cancer and sun protection. Sun does a lot of great things for us, makes us feel good, but just like everything else in life, moderation and sensible use is the key here, all right? Because UV radiation is on the World Health Organization's top 5 list of known carcinogens, right up there with asbestos and cigarette smoke. And so that's what leads to skin cancer and need to come see me. Although you'll have a great time when you come see me, I hope you don't have to, okay? I hope you don't have to come see Mike either. He's a wonderful doctor and a great guy, but there again, we'd rather not see you. But if you do need us, we're here to help you. So here's our dermatology team. We've got Dr. Schuster, myself, and Dr. Teoker. We're available in Fond du Lac, Ripon, Mayville, Waupun, anytime you have a problem. So what is skin cancer? Well, skin cancer, cancer cells are cancer cells no matter what they are. They're cells that just don't behave properly. They grow too rapidly. They like to leave the area where they're supposed to be in, and that's what gets people in trouble, okay? So, like I mentioned earlier, UV radiation is the leading cause of skin cancer, but there are other factors that contribute to it. Family history, are you a smoker? Cigarette smoke increases your risk of skin cancer, okay? So there's different things that are involved here. You know, what types of skin cancer are there? Well, the most common kinds are basal cell skin cancer, squamous cell skin cancer, and melanoma, and that's where we're going to focus on. There are many other skin cancer types, but they're just a lot more rare, and we just won't cover that today. Why should you care? Because between 1 in 5 and 1 in 6 people are going to get a skin cancer. That's a lot of people. So, you know, we must have about 40 or 50 people in here. Well, that means about 10 of you are going to get a skin cancer at some point in your life. And that rate is ever increasing. And that's because we have more time outside and we get more exposure to UV radiation. So how do you know if you have a skin cancer? Well, I guess the first step, you have to know you have it. Well, signs that you can look for are anything that grows rapidly, bleeds easily, and doesn't heal. As we get older, you know, most of us when we get into our 60s and 70s don't get pimples anymore. So I hear, Doc, it started out like a pimple. Well, when's the last time you had a pimple? It was 40 years ago. That's not normal, right? So if you get a spot and it doesn't heal up in 3 to 4 weeks, that's abnormal. You should get it looked at. Okay. Other things we look for are the changes in size, shape, and color. Irregular borders, irregular color, large size. The ugly duckling of the group. If it doesn't look like anything else, maybe it's time to get it looked at, okay? Because that's the first step. You need to have it evaluated. So what do basal cell skin cancers look like? Well, the most common kind, and the easy ones to pick out, are these sort of raised, pearlyish pink bumps. Sometimes they'll have a little erosion in the middle. Okay, so that's the most common kind, and they can pop up everywhere, anywhere. Here's another one on the cheek, raised, kind of pearly nodule. Another one here on the nose. And finally, if you just wait too long, this is what starts happening. You get this large red plaque just all over. That's a problem for you, okay? That becomes a little bit harder to treat. You're probably going to see my friend Mike to get that one taken care of, okay? Because that becomes to be a real problem for people. So the whole thing is, don't wait too long. The sooner you get it taken care of, the easier it is to treat, the more options you have, the better outcomes. So what does squamous cell skin cancer look like? Squamous cell skin cancer can have a lot more variation than most basal cells. Here in this corner, we have a red patch. It's just a large red scaly patch. This has probably been present for over a year. It's just a persistent red scaly patch. It just never goes away, okay? So we have that one there, spins around. larger, red, raised, ulcerated nodule on the nose. Okay, there again, just not normal, all right? On the ear, rapidly growing bump with this central crust, very common for squamous cell skin cancers to appear very rapidly. And here again, another raised red patch on the back of the hand. So just kind of a persistently scaling thing, might bleed kind of easy, never goes away. That's just not too normal, all right? Melanoma. These are the ugly duckling of brown spots. It's a little bit harder to maybe tell with the lights on here, but a lot of black over in this area, really irregular jagged border. We got some white appearing in a couple of these areas. That's just not right, okay? That needs to be taken care of. Really dark black spot, a little bit hard to tell in this photo, but a little bit raised. It's probably changed over time too. This is getting larger in diameter and size. Here again, we got a raised black portion, this big white area. None of that's normal. So dark black raised spot, this was probably not there, okay? So it's normal to develop new moles up into your mid-30s, okay? That's generally normal for most people. There are a few that will develop new moles after that. This is kind of a new mole on somebody in their 50s. That's really not normal. So although it doesn't look nearly as bad as the rest of these, that's the kind of thing you need to be looking for because you're the first line of defense. You see yourself every day. You don't come to see me every day. So if you see something, you need to go get it looked at, okay? Maybe it's nothing, maybe it is something more important, okay? So how can we treat skin cancer? There's lots of different ways. We have curettage and desiccation. This has been around for, as long as they've probably been treating skin cancer. There's some topical chemotherapy that can be appropriate for certain types of skin cancer. There's standard surgical excisions. Then there's Mohs microscopic surgery and radiation therapy, and they all have a role. So what is curettage? Well, curettage utilizes a sharpened loop on a stick. And what you do is you scrape the skin cancer cells away. And it works actually pretty darn well, and we use it a lot on the trunk and the extremities. It heals very easy. It'll heal with a little round scar about the size of your tumor was. And it works because skin cancer cells don't stick together very well and your normal skin does. So I kind of liken it to having a bowl of pudding, and the pudding is the skin cancer. And you take your spoon, you can get all the pudding out and the bowl stays there. Well, that's what it's like. So for appropriate basal cell skin cancers and some squamous cell skin cancers, when they're on the trunk and the extremities, it works very well, okay? Topical chemotherapy. This is an interesting way to treat some very early forms of skin cancer. The benefit of like a topical medicine is that it can heal without a scar, which is really kind of important because there's only one other possibility for healing without a scar, and that's radiation therapy. Okay, so those can heal without a scar. The downside is they're limited to what you can use them on and the duration of treatment. You're going to have to treat somewhere between 8 and 16 weeks with this, and while you're doing it, it gets really red and angry looking. But if you have a large, very early skin cancer on your face, that if we treated with surgery would leave a big scar, no matter what we do, how well we do it, you will have some scar. It might be a nice option to consider, okay? So here's a little picture of curettage, and what you do, you have a little sharpened loop right here, and you just scrape the skin cancer out. And here's the same thing right over there. We're just scraping the skin cancer away. And it does work pretty nice for a lot of people. Standard surgical excision. When you do a standard surgical excision, you identify the tumor, you draw a margin around it, and you cut it out. And you see here they've made it into an elliptical shape. That's the most common way to do this because you can't, to close things like this, you have to close it usually in a straight line. Because you're not looking at the pathology in real time. You're going to cut this out and send it to a pathologist who slices it like a loaf of bread, and then they look at those slices underneath the microscope to tell you if it's gone or not. And if it's not gone, you have to go back and take more out. So if it's a straight line, you just come back right in the middle and you take some more out. It works pretty darn well for certain basal cells and squamous cell skin cancers, and it's the standard for most melanomas. So it's got a cure rate of about 92%. I use this mostly for melanomas and just a few other skin cancers. Radiation therapy. Radiation therapy has a very good cure rate, 97%, and it can heal without a scar. It's generally really well tolerated. You go see my friend Mike, you go lay down on the table. Once they got it set up, it doesn't take too long, okay? But it does take quite a few treatments, and it's fairly time consuming. We use this for a lot of the larger basal cells, like that one that was taking up the whole cheek. That would be really hard. I mean, it would be hard to put it back together. It's easy to cut it out, okay? It's the putting it back together. When you're involving that much space, it becomes really challenging to put it back together and have it function properly and look good. So that would be a great candidate for radiation therapy. We also use this to decrease the risk of metastasis for some very high-risk tumors like squamous cell skin cancers that are really aggressive and some different things like that. So it has a lot of application. It's great that we can kind of tie that in. We're one of the few locations where we can tie in all these treatments into one easy-to-use package. Mohs microscopic surgery. I do this every Wednesday. This is for select tumors, primarily on the head and the neck. It's an extremely precise technique. This has the highest cure rate of any treatment for skin cancer at 99%. You just will not get better than that in anything in medicine, right? We won't label anything 100%. So 99 is close you're going to get. The reason it's so precise is because of the technical aspects of how we cut it out and process it. And I've got some slides that'll kind of show you a little bit of the difference between a standard excision and a Mohs microscopic surgery. We use frozen section specimens right after we remove it. I look at those slides. If we find tumor, we go back and take more out. If we don't, we can close it. Because it's so precise, we have more options for putting things back together. So this gives us a lot of ability to help maintain cosmesis and have really good outcomes that way. So we can also use this for some melanomas. So certain melanomas on the face we can treat with Mohs surgery, which helps provide better cosmetic outcomes for the patient as well. You start getting into some of these melanomas, you have to do really large margins if you're doing a standard excision. The bigger the hole, the harder it is to make it come out and look proper. So being able to keep those margins down, make the hole as small as possible, and know you've got the skin cancer out gives you the best outcomes long term. So here's a little basic slide that kind of tries to explain the process. So we have a patient who has a tumor. We're going to remove a layer. We process it, look at it under the microscope. If there's some tumor left in a specific area, we are now going to go back in this specific area, take out another piece, reprocess, look at it. Now it's clear. We can go back and decide how to put that back together to give the best outcome. And those outcomes, what we do to put it back together depends on the size, the patient's age and tolerability, and their desires. We cover all the options that you have and then let the patient make the decision. Sometimes the patient has something in mind, sometimes they say, whatever you think, doc, and so we help to work with them. If they're gonna have problems taking care of it, we're gonna find something that's a lot easier to take care of. Maybe instead of doing something that might give them a better cosmetic outcome. Maybe they care more about that, or some people want a better cosmetic outcome, then we have to go to a little bit more extended measures. Might be a little bit harder to take care of, but you're going to get a better outcome. So a lot of people will make choices, different choices. So how does it differ? This slide shows a Mohs excision, and a Mohs excision here, and a frozen, a standard vertical section here. So when you remove a piece using standard technique, you cut it out and then slice it like a loaf of bread, and then they're going to look at these little ends of these sections. Okay? It's really good for telling you what's in the middle, but obviously you miss everything that's in between these sections on the outside. And when we're removing the tumor, it really doesn't matter anymore what's in the middle, it's what's on the outside that we're really interested in, right? So you can, in cases, use this technique, but it has some limitations. Well, with a Mohs section, you remove it in a different manner. It's cut out, and it looks sort of like a pie plate. When you remove it, it looks like a pie plate. And then you take that pie plate and put it on a cookie sheet. And then you're going to take the edges of that pie plate and smash it down onto the cookie sheet. So now that outside edge, all the sides and the bottom, sit right along that cookie sheet. And then we take and we slice it very thinly from the bottom up. So now when I look at a specimen, I see all the outside edge on the top, along the sides, and all the bottom every time I'm looking at it. This is why it's so precise. You see all the edges. And so if there's one little strand of tumors coming out from that, one little string, we can find that little string and then go back and make sure we get it all. So here's a little section, a picture depicting the surgery again. So here's your tumor, okay? We're going to take a little bit of normal tissue and that tumor and we cut it out. We process that. If we have to go back, because it's positive down here in the deep portion, here's that little finger that's coming out. If this fell between our normal sections, we'd miss that, but we're not going to miss it because it comes here. We say it's positive, so we take out another layer, and we can see that it's positive again because there's this finger here. So we take out another smaller piece right there, and oh, look at that, there's another little finger. We see that, we go back and take out another layer, and now it's finally clear, okay? But because of this, we can do that, okay? So it helps you minimize the size. You don't have to keep going larger in the surface area in this case. We only have to go deeper, okay? The depth usually doesn't matter too much. It's the surface area that makes it more challenging. So here's a little depiction of a doctor looking at the slide. Here's a map, a picture of a map we use. So when we remove the tumor, we put little hash marks around it. We use 2 hash marks at the 12 o'clock position. So we designate what's going to be 12, and then a hash mark at 3 and a hash mark at 6. So now when we look at this specimen under the microscope, we know where we're at when we're looking at it. So it's you can orientate yourself. And then we also use tissue dyes, and it might be a little bit hard to pick up here, but there's some ink here on these pieces. So we've cut it out. We put 2 hash marks, 1 and 1. Then they also put ink on these specimens so that when he's looking at it under the slide, he can see exactly where everything is. If there's some tumor right here on this edge at the 10 o'clock position, you can identify that because you know exactly where you're at with hash marks and tissue dyes, and you know exactly where to go. So you're not going to remove any more than you need to. And while we're waiting, our patients get bandaged up and they're always happy, okay? Always happy. So you wait for the tumor, so there's downtime. So although the surgery goes rather quickly, there's a lot of downtime because it takes time to process that tissue. So in the meantime, to take out that first layer surgically only takes about 15 minutes in most cases. You just numb it up. That's usually the worst part. That's not too bad. And then we take it out, and then we put a bandage on it. And then you have to wait. So either they go out to the waiting room and watch TV, or they go sit in the side and they do cards, or they read, or they do whatever they want. And then when we know what we have to do, we go back and take care of it. Either take more or we put them back together. Most patients need between 1 and 2 layers to get everything out. Okay, so that's most tumors. However, there are exceptions, right? There's some that might need 7, 8 layers before the tumor is clear. It can happen. That's a long day. But you know, you can eat and drink. You're awake the whole time. You're not under general anesthesia. Some of my patients with larger tumors that are going to be really big, okay, it takes a long time to process that. Well, we know that, and we tell them that going into it, like, hey, you're going to have time. We'll put a bandage on. If you want to go grocery shopping or do whatever, and they do. So you have a lot of freedom that way. So what do you do after you're done? So here's a woman that had, unfortunately, 2. We did them both at the same time. And so this becomes a challenge to put back together because they're large. And they're on her nose. You don't have a lot of extra stuff there. So we did 2 different things. We did 1 full thickness skin graft. So we borrowed some skin from someplace else and we put it on there. And we also did a synthetic material. I have fake skin that we can put in there. And I just decided to do one way and one the other to see how it was going to work out. This is all healed up. This is the full thickness skin graft. Here's the synthetic. You'd be hard pressed to find that one. This one, it was a little bit bigger. It's still a pretty dang good result. Most people wouldn't know it. And if she chose to, and I usually offer it to any patient, there's a little bit of lip right here, okay? And I would come back if we wanted to and clean that up for them. You could numb this area up and basically take what's called a dermabrader, which is like a little sander, and you just sand off that little ridge, and then it heals up really quickly, and then you never know it was there. But she really didn't care. She was happy, and so that's fine. So here we have another patient. She waited too long, okay? And so she ended up losing a large portion of her nose, and it's a little bit graphic, but her nose is missing right there. So this becomes more of a challenge. So now we have to go to a little bit more extreme measure, and this is going to be a little bit harder for her to take care of, but essentially what we're going to do is we're going to take this piece of her cheek, okay, and this little piece right here. This little piece is going to be the new inside of her nose, and this is going to be the outside. But she's also missing the rim, so we need to put a new piece of rim in there. So we're going to make a rim from her ear. We're going to take a little bit of cartilage out right there. She'll never know that's gone. We're going to use that to make a rim. Okay, that's the inside, that's the outside. Here's your rim. And to keep it alive, you got to leave it attached right there for about 2 or 3 weeks. Okay, so she's got essentially a finger coming out here and stuck to her nose over here for 3 weeks. Okay, with that cartilage sewed in between. So she's got to take care of this. And so here she comes back at 3 weeks. It's healing up really quite well. Now what we're going to do is take that apart right there and then readjust this so that it all fits in quite nicely. And so here's right after we did that. Okay, this is a week later after it's been all sewed down. And here's what her nose looks like probably 6 months later. Okay, so the cheek looks good and the nose is hard to tell if there's anything really been done there. And here it is even later. You can't even tell we're in there. The nose works, okay, so when she breathes in, it doesn't collapse, and it looks pretty much the same as the other side. So we have a lot of different things we can do. Here's a fairly large one here. We're just going to rotate some skin from down here to close that up. So here you can see what we're going to do. We're going to make an excision there and slide that all right in. And that's what it looks like when it's all sewed up. And that's what it looks like closer up. And there's probably a week or 2 later after we took the stitches out. It's already come along pretty good. And then that is about 6 months later. And you can't really hardly tell it was there. So, you know, there's different techniques we use. Here's a pretty simple, straightforward one, not that big on the side of the cheek. You have a lot of options. So we don't have to get real fancy with this one. So we're just going to make it a little straight line closure. You know, we all have straight lines on our face. And if you can blend it in with one of those, you'll never see a scar. So that's what it looks like right after we're done. And here's probably like a year later. I don't know, if I didn't tell you, you probably couldn't really find too much in here. It should be right over in here someplace. So on the back of the ear, okay, this is the ear, that's the back of it. We're actually just going to pick up some skin from here and move it right over there. Sorry it's fuzzy, but that's what it looks like all sewed together. And that's a little bit better picture of what it looks like a week later. Okay, here's a pretty big one right here on his forehead. This poses a challenge, but we have some lines going this way on our forehead, so maybe we can help, you know, maybe we can use that to our advantage. So we're going to borrow some skin from this way and some skin from this way, and we're going to sew it together. It's going to look like a little bit of a Z right here. All right, so that's a week later. We took the stitches out, so I think that doesn't look so good, Doc. Well, here is just a couple months later, and you can't really see anything. Okay, so that's coming out pretty dang good. So that's Mohs surgery and then the reconstruction. So there are a lot of options available to there, and every patient's different. So how do you not come in and see me? Which is really important, okay? Because the best thing is don't get skin cancer. So you may or may not be able to prevent it, but there are certain things you can do. Protect yourself. You've got a wonderful sample of sunscreen here. The Neutrogena product line, and I don't get paid to say this, is actually pretty good for technical reasons. It just works better than most commercially available sunscreens that don't use zinc. But that takes us back to zinc-based sunscreens, and they are better. The reason they are better is because they cover more of the spectrum of UV radiation than chemicals, and they physically reflect the sun off your body. Whereas the chemical sunscreens absorb it. And when they absorb that energy, they start to break down. Well, if it's breaking down from sun exposure, how is it supposed to help protect you from the sun? It can't, right? Zinc will never do that. Now everybody might think, if you go back long enough, they remember the zinc, the big white nose, or they think of diaper paste. Well, that is zinc, But modern technology has advanced it so that it's micronized, so that when you put this stuff on nowadays, you can put it on and you don't even know you're wearing it. The problem is finding zinc sunscreen isn't as easy, okay? Fortunately, around here, Agnesian Pharmacy, a year or so ago, because of a patient who had skin cancer and had it treated, went online after I talked to her about sunscreen and bought some and said, hey, this is all right. And she works at the pharmacy. She convinced them to start selling some different zinc-based sunscreens like the Blue Lizard family of products. And there's a couple other ones. So at least in places like Waupun and Fond du Lac and Mayville and hopefully Ripon, you can buy some zinc-based sunscreens over the counter. And they work. You can also buy them online, and they just work better. So you have to protect yourself. Which leads us to the blue tent over here. You say, why is there this big blue tent in here? Well, this is a project that I've been working with Molly and Holly and the rest of the staff to help provide sun protection for the community, for youth in the community. A lot of our sun exposure comes when we're younger and we don't think about it, right? We don't really think about skin cancer and things like that when we're in our preteens and in teen years. And a lot of that exposure comes to people playing outdoor sports like soccer and baseball. And you go to a soccer field or the soccer complex, I dare you to find a tree, right? I mean, they're just not there. Well, it's kind of hard to have trees in the middle of your baseball field or your soccer field, right? So there's a program started by a friend of mine called Sun Safe Soccer. It's through the American Society of Derm Surgery. And it has two prongs. One is to teach people about sun safety. Teach kids, to put sunscreen on. It has a simple little slogan, sunscreen then shin guards. So it works for soccer. And then a cool down, cover up, and cool off. And so part of that is we extended the message and said, well, what if we can provide safety shelters, sun-safe shelters for people to use? So Agnesian HealthCare has donated over 100 tents in the last 2 years. And they have the Agnesian logo on them and the sun-safe soccer, and they're going to be used throughout the community of Fond du Lac and Dodge counties, and we're going to continue to expand it as much as we can. And so protection, covering up, protecting yourself is the best way to prevent skin cancer. Also, never use a tanning bed. It is extremely high dose UVA radiation. It penetrates deeply. It increases your risk of skin cancer 75-fold. That is tremendous. So if you already have 1 in 5 or 1 in 6 people getting skin cancer and you just increase that like 75 times, it's like guaranteeing you have a skin cancer. All right, so avoid it. Spray-on tans, self-tanners, a very reasonable, safe alternative. You'll look like you're tan, but you didn't hurt yourself. And then you also prevent the cosmetic damage that comes with it down the road, the wrinkles and the brown spots that you're not going to like. So what do? Okay? Protect yourself from the sun. Regular self-exams. Take a look at yourself. Look for the ugly duckling. Look for the spot that won't heal. If you notice something that's not right, go get it looked at. Okay? Because the first step is getting it evaluated. Maybe it needs a biopsy, and that's where it all starts. So now I believe Mike is going to talk to you about radiation therapy and how we can use that. So make a quick switch here, and thank you for your time.
Hi, my name is Dr. Mike Vanderkoy. I'm a radiation oncologist over at Agnesian Cancer Center. Appreciate the opportunity to talk to you today. First of all, I just want to say Happy Mother's Day to all the mothers. And I want to tell you a story about my mother, who I dearly love. So my mother was diagnosed with squamous cell carcinoma of the skin this last fall. And she really kind of had an uneasy feeling. She lives up in Wausau. And I said, I finally found out, and I said, Mom, you need to go to the best dermatologist I know, Dr. Burt Steffes. So Dr. Steffes was very accommodating. My mother and father came down early one morning, and Dr. Steffes did a consultation and actually did a surgical excision the same day in the office. And my mother for the next week was going on and on and on about how Dr. Steffes actually talked to her and my dad, how he explained all the options to her, and just how impressed she was with Dr. Steffes. Then she subsequently had her stitches removed later, about 10 to 14 days later. The doctor up in Wausau, where she lives, was so impressed. Frankly, they were asking my mom, well, who did this? Plastic surgeon at UW or Mayo? And it was actually Dr. Steffes. So I want to thank Dr. Steffes. He's a very talented doctor, and we're lucky to have him here, especially doing all the Mohs microscopic surgery, but just taking great care of patients in general. Thank you. I also want to celebrate, this is National Nurses Appreciation Week, May 6th through May 12th. Just thank all the nurses, not only at Agnesian Cancer Center, but the whole Agnesian healthcare system. We're really blessed to have such great nurses, and without the nurses at Agnesian Cancer Center, we really wouldn't be able to provide such a great patient-oriented treatment. And I want to thank all the nurses again, not only at Agnesian Cancer Center, but I see some wonderful nurses here from radiology and all the other areas of St. Agnes and Fond du Lac Clinic and Waupun and Ripon. We wouldn't be able to do it without you. So thank you very much. So anyway, I want to introduce the team. This is the Agnesian Cancer Center. You can see the team here standing in front of our new sign. We recently renamed our cancer center from the Central Wisconsin Cancer Program to Agnesian Cancer Center. And we have a wonderful team of nurses, therapists, front desk staff, social worker, and dietitian. I'm wondering if everyone from the Agnesian Cancer Center could stand up, everyone who's present today. So, Ann Sargent, our nurse supervisor, Liz Hill, our dietitian, and Christy Martin, our social worker. We all work together as a team, and it's really important. Here is the physician team. Dr. Michael Jones is a medical oncologist. Dr. Tim Karitko is a radiation oncologist. Dr. Joel Lundberg is the senior medical oncologist, and then myself. So, Dr. Steffes really so eloquently outlined the role of surgery and in the treatment of skin cancer. External beam radiation therapy has been used for years for the treatment of skin cancer, and so what I'm going to talk about is predominantly external beam radiation therapy for the use of basal cell and squamous cell carcinomas. External beam radiation therapy can also be used now in melanomas. There's some data that if patients have positive lymph nodes after melanoma surgery, there is a role for radiation there. But I'm primarily going to be talking about basal cells and squamous cell carcinomas here. This is our state-of-the-art linear accelerator, which produces high-energy photons and high-energy electrons. Typically, we use electrons for treatment of skin cancer. And this is our Ovarian Trilogy machine, which Agnesian has so kindly provided us. It's a wonderful machine. We can do not only electron treatment, we can do three-dimensional treatment planning, we can do intensity modulated radiation therapy and stereotactic radiation therapy. The great thing about this machine is, number one, it has this as an imager on the other end. So this is where the radiation comes out of, and this is the imaging equipment. So we can do a lot of intricate treatment planning where we do image-guided radiation therapy, where we can take a KV image or do actually a small little cone beam CT image also. So it's a wonderful machine, and Agnesian really has supported us in developing our radiation program, and I want to thank administration for that. Now, we also have a robotic table. We were the first one to have this robotic table. It has 6 degrees of freedom, so it allows us to kind of make fine movements to the patient in 6 6 different dimensions. And so it really allows us to precisely set up the patient and position things so that we can precisely treat every patient. And with radiation therapy, the key is it's not only a machine, but it's immobilization. Yep, it's immobilization, and thank you. So a little show and tell here today. So the immobilization devices are important too. So this is one of our immobilization devices we use in some of our head and neck cancer patient or upper extremity or lower extremity patients where we will mobilize the patient. This bag forms, we can take the air out where we can immobilize it around the patient and around, for instance, if they have an extremity lesion, or sometimes we even use it around the head if our cup holder isn't fit properly. And I can kind of pass this around if you want to just see. This is, and it can kind of conform to the patient. You can pass it around. So immobilization is key too, because we want to make sure the patient's in the exact same position every day. I don't like moving targets. I was never a good hunter, so when things are moving, I just can't hit them as well. So with treatment of basal cells and squamous cells, what we do is the radiation will come out of the head of the machine, but we want to kind of collimate the radiation so it hits just the area we want to treat. Thus, we do customized electron blocks where I will identify the tumor in a simulation and then actually create an electron block. Subsequently, this is made out of lead and it's quite thick, so the radiation only goes in this area here. The area that's blocked will get no radiation. So to collimate our radiation, kind of be more precise with our radiation. And this is really key, especially with head and neck areas where we're trying to treat the cancer but minimize treatment to normal critical structures such as the eyes, try to minimize oral cavity dose. So we use the customized blocking for that. And thank you so much. And you can see this is an example of one of our lead blocks. I always like show and tell, and so now a few clinical cases. With radiation therapy, it's important to identify the basal cell or squamous cell carcinoma. This case is a recurrent squamous cell carcinoma in the earlobe, and identify the lesion, but also then create the proper immobilization device to get the patient in the proper position every day, and then create a customized electron block. Then what we do is use the appropriate electron beam energy, and we use a bolus material also. So this is a patient back about a year ago with a squamous cell carcinoma, a recurrent squamous cell carcinoma of the earlobe. Actually, do you have the bolus material? So what we do is Agnesian HealthCare has provided us with wonderful machines where we have all these different types of energy, photon beams and electron beams. So again, they provide us with the different electron beam energies. We have multiple different electron beam energies, and what we do is we do CT-based treatment planning, and then we calculate what the most appropriate electron beam would be. Well, when you use radiation, especially when you're treating a skin cancer, you have to try to maximize the dose to the skin surface. So what we do is we do certain forms of tissue compensation where we try to bring the dose up to the skin surface. So we have different types of tissue equivalent bolus. We have 0.5 centimeter, 1 centimeter, we have 1.5. And so this is what we actually, when we do our treatment planning, we lay this on the patient's skin to bring the dose up to the skin surface properly. And you can pass that around. So that's what we do as far as tissue equivalent skin dose bolus. And that's clean. You don't have to worry. It's never been used on a patient. And so that's one of the ways we can kind of bring the skin dose up properly, because even with electrons, most of the doses deposit shallowly, but we want the maximum dose really at the skin surface and in. And we can use different energies of electron beams and different thicknesses of bolus to get it at the skin surface in very depth and how deep we want the radiation to go. So this is one of my patients. Again, same patient with the squamous cell carcinoma of the earlobe. Now, you can see here, don't be alarmed, he's immobilized. He's immobilized on the table with a customized headrest, and this is a customized aquaplast mask. So the patient is immobilized. And the aquaplast mask is critical for our head and neck cancer treatments and any skin cancer treatments. So what we do is at the time of the treatment planning, we bring the patient in the room and we warm these masks. These are customized aquaplast masks. This is how they look when they come from the vendor. So, but when warmed up, they're very pliable and can conform to the patient's face. So it's like giving the patient a warm facial. You warm them up and you gently put this over the patient's face and let it harden. It will harden over the course of 15 to 20 minutes. And the patient will be immobilized in a mask like this. Now, most of our skin cancers, we want to get good exposure, so we use more of a mask like this where they can see and breathe through it, and we also kind of reinforce it with aquaplast. But you can see how resistant that is, and how really when we get them locked down on the table, they really can't move. Again, finding different ways so that it's not a moving target to make sure they're completely immobilized every day for treatment. So this patient has the customized aquaplast mask on, and also different technical things. I put a piece of gauze in the ear canal because radiation works best if it's a nice flat surface and there's not any real divots. So this is a demonstration of the patient. It may not project well. Same patient with a recurrent squamous cell carcinoma of the skin. And you can see this is our customized electron block on X-ray. You can see this is the area getting radiation. And you can see we're blocking, this area here is not getting radiation. So the darker area is receiving the radiation. And we're able to block the anterior oral cavity, block the eye, and block the normal critical structures with using the customized electron lid block. And this is a digital reconstructive radiograph, where this is a reconstruction on the computer when we do the treatment planning. We do CT-based treatment planning on really almost every patient. And with this, we can, so we use the combination of CT planning scan and immobilization to come up with a customized block with different varying electron beam energies. And you can see this is the customized block we created on the computer with the tumor and some of the surrounding tissue. We definitely put margin on because electron beams, from a physics perspective, can constrict at depth, so we want to make sure we put margin around the tumor also. And again, we do all CT-based treatment planning to make sure we have adequate margin around the cancer. And here's a demonstration of the tumor here a few weeks into treatment. You can see the kind of the reddening of the skin. You can also see, this is good, this is areas becoming necrotic, and it's responding to treatment. And this is a few weeks later into treatment. You can see it's continuing to respond to treatment, and it's definitely shrinking, but you can definitely see the skin erythema, a redness around the lesion, which can occur. I'm sorry. Okay. So this is another picture of another patient who, this does not project well, with a nose cancer. Don't be alarmed. She's got customized Aquaplast mask on, and she has eye shields on, actually. And so we also can use different things when we're near the eyes or even the mouth. For instance, I have a patient I'll be treating soon where we're trying to protect the teeth, where we use lead, and we can put almost like a denture-like material around it to protect the inside of the mouth. But this is an example of a lead shield for the eye, or you can put a lead shield on. And so anyway, in summary, it's an honor to work for Agnesian HealthCare, but it's an honor to work with someone like Dr. Burt Steffes, because we work really well as a team to treat skin cancer patients effectively, and all these different modalities are really important in the treatment of skin cancer. And we're very fortunate to have Mohs microscopic surgery here, and we're also very fortunate to have such great radiation equipment. Now, this is just a demonstration of the Cancer Center. This is Dr. Michael W. Jones letting down his hair. And that's Dr. Lundberg. And actually, that's our lovely dietitian, Liz, who's in the audience. This was at the Pink Glove contest. And again, there's Bill Daly, our director. There's Dr. Lundberg again. And there's Mike Jones laying down his hair again. And we do a lot of things with the community, too. It's great to be a part of Agnesian Cancer Center because we're involved in a lot of community events. This is the Relay for Life event where we had roasted pig. And these are all members of our team: Dr. Jones, Dr. Lundberg, Bill Daly, and actually that's my son, myself, Chris Blonigan, who worked for Agnesian at the Cancer Center for years, but now is a nurse navigator at the hospital, Nikki Wirtz, Bill Daly, and Mike Jones. So we try to participate in as many events as possible, Relay for Life. We actually have a Cancer Survivors Day, which will be here on June 2nd. And it's great being a part of this community, and I feel blessed to work with Agnesian Cancer Center to provide such great service for you. So thank you so much for your time.